Thanks. I'm going to encourage folks to start coming to the microphones at your leisure, and I promise we'll get back to every of the panelists. But as you all formulate your thoughts and come to the microphone, I want to turn to memory and ask you, this is a scientific meeting, and all this data comes out. And actually, GNP Plus put out a statement just the other day reflecting on all of this information. But we have this situation so often where there's treatment, prevention, and again, on the ground, in the network, how are you grappling with this? What are the issues that you're sensing and wanting to deal with above and beyond what is clearly in the science?
Thank you. We're calling for basically, the human rights best guidance on PrEP and IAS prevention. This is very exciting, and it gives both partners in a discordant relationship the ability to choose what works for them and to reduce the risk of transmission. And I would like to see a little more work done on this, where cost doesn't sort of stop access to this new technology. And also would like to see more research on women who, especially in limited resource settings, so that there's continued research on microbicides, for example, and any other tools that women can use safely and comfortably and use without worrying too much, and also make more female condoms available. And also would like to call on the agencies like the WHO and the UNAIDS to develop a guidance and working with people living with HIV especially on how to get this moving, and also work with people who are going to provide the service, and so people can make a choice on what works best for them. And also there's a problem in areas where people still get criminalized, and there are uncertainties about the use of ARVs for prevention for both positive and negative people. So there should be supportive policy and legal environments that are essential to enable individuals from key population groups to access, without fear of discrimination and violence, this HIV testing and access to prevention, treatment, and care. So I think that's where we kind of stand on a human rights basis. Thank you.
Great. Thanks, Memory. Again, please start coming to the microphones. I know you're tired, but I can't believe there aren't questions. And I was just going to lead on what something Memory said, but I thought I had a second to ask someone else a question first. But let's go ahead and take a question. Again, I'd ask you to stay very brief because we want to get as many comments as possible. So let's go to the back, gentlemen, and then we'll come up to the front. And introduce yourself, please. Yeah.
I'm Stefano Orlando from the DREAM program community of Sant'Egidio. And my question is very briefly about PMTCT, because when we talk about treatment as prevention, I think we have to think about PMTCT because we have a lot of experience, even the one we had in our program, 20,000 women treated with antiretroviral therapy that didn't transmit, with 2% transmission to their babies. And I think when we talk about this, the next step on PMTCT, given this data we heard yesterday, is to give antiretroviral therapy to all pregnant women, irrespectively from their health status, in order to get zero infection in babies, in order to reduce maternal mortality and so reduce the number of orphans, and to reduce the risk of transmission in other cases.
Great, thanks. Why don't we take the other question while you're standing, and then we'll get back to the PMTCT as well.
I'm Patricia de Fischre. I work at the Gladstone Institute, and I wanted to ask the panel how long before you will consider implementation for the young population, the teenagers, because all the PrEP studies have been conducted in adult population. And I've asked this question before, but I'm really anxious. I feel we really need to address that question.
No, I'm glad you're asking it. For all of those in the room under 18, raise your hands. Okay. Oh, yeah, right. Let me actually put both of those questions to start, at least, with both UNAIDS and WHO. Maybe, Paula, if you wanted to look at the PMTCT question, and I think as the data was all coming out around treatment, we also had the UN high-level meeting taking place in June, which really focused so much on PMTCT. So I wonder if you want to take a swap at that one.
Yeah, I think certainly the momentum for elimination of infant infection has been building for the last couple of years. We all expected after the short course AZT and single-dose nevirapine trials showed efficacy and effectiveness back in 1999, 2000, that this would have gone much, much faster than it did. And I think it was a lesson that we need to keep coming back to, that some of these technologies that we think are relatively simple are not so simple. And they require components and systems that are not strong. They require human resources, a whole range of things that everyone in this room can identify. And I think we have to be aware of that as we confront this whole range of new biomedical tools. I would like to touch on something that the memory said. You know, when we get into PrEP, this is not going to be an anonymous tool like a condom. You are going to need to go in and be identified and work with a care provider. And basically you are there to ask for protection during risk behavior. And if you're in a country where that is stigmatized or criminalized, PrEP's just not going to be possible. I think we have to put that on the table.
Great, thanks, Paul. Gottfried, maybe you can also look at this issue, but specifically the question of adolescence, but I think it fits into something else that Memory brought up in terms of the guidelines. And you know, I wonder, and I think many of us wonder what next for guidelines. Now we have all this data, so perhaps from a WHO perspective, when might we see ARV for prevention guidelines?
Thanks for the question. And I want to sort of build on what Tony said. Sort of the cascade. We have science, translating into policy, translating into implementation. Where do we see as WHO our prime role? Obviously, it is to respond to science, but to translate this into policy guidance that is meaningful and useful to countries in a way that they can make informed choices, that they can look at the various options. And I think clearly what we have been seeing is we are going to talk about options, about the use of ARVs in the future, and what is the best bundling of guidelines, in other words. Countries often tell us, okay, you're just shooting down guidelines. As soon as something new comes up, you're sending us a new guidelines, but you're not telling us often how to best put it all together and how to best really make some difficult choices. So I think we see a responsibility, and now in this very specific situation where obviously some of the conversations becomes a bit fragmented. Is this about treatment, or this is about PrEP, and somebody talks about ART for prevention, somebody talks about PMTCT, to really bring some rationalization in how can we best and most strategically use this incredibly precious commodity tool, ARVs, that we have, so that it actually obviously keeps those who are sick alive, but also that we use optimally the prevention benefit that it also offers. So in terms of a next step, what we see is we have started already serodiscordant couple guidelines, because we feel, and it's not only on serodiscordant couples counseling and testing guidelines, because we see this is an incredible opportunity for bringing men into services, for mutual disclosure, for possibly getting in treatment, support to adherence in the couple, etc., but also to look at possibly other prevention options in a couple situation. The same we will have to do for other situations, key populations, for example. But at the same time, we are consulting now with key partners, scientists, implementers, to say what would be the most logical increments in guidance. Should we, as soon as a new research study come out, translate this into saying, well, you should do this and you should do that? Or is there sort of a threshold for saying, well, as soon as we know a few things, like how would ART for prevention could be applied across the board, would that be the best moment to come up with guidance? As soon as we know how PrEP plays out across various situations, maybe some of the niche situations that PrEP might be most useful in, how can we best guide countries? On adolescents, I think, yes, PrEP, we have findings about PrEP in specific situations. We need to discuss with the researchers and those who fund research whether looking into adolescents would be sort of the logical next step to expand on.
So without putting you too much on the spot, what's your best guess of when you might have WHO guidance around ARVs for prevention?
As I said, we are really counting on support and really advice from people around the table here and others in saying, well, what would be the most logical next product, and by when can we deliver that? Actually, hopefully within a year.
Okay. Let me, Tony, and then Bob and Helen.
Just very briefly, I was very heartened by the intelligence of the two questions, because they really relate to what we were saying and what Helen actually said that's very important. And that gets to the science of what a proposal you're making, would it really work or not? And how does an individual country adapt the scientifically sound approach that's relevant or even possible in their country? And I think we need to be fair to WHO. Peter Piot, in his discussion, I forgot whether it was yesterday or today because it's all blurred, put up the point about guidelines versus whether or not you can actually implement a guideline. So if you take in a vacuum, if you treat pregnant women, all pregnant women, A, it's very good for the pregnant woman. B, it is extremely unlikely that the child will be infected. And C, it's extremely unlikely that the child will be infected through breastfeeding. So then you look at the situation in your country of whether or not you're able to implement that right now. The question is adolescence. Do you have a situation where you can actually get to adolescence or not? You talk about PrEP versus treating the partner who's infected. That's really clear that if you are in a situation in general, and again, because it's going to be different from different countries, if you have a partner that's infected, not putting down PrEP, because the partner's PrEP study was a very important study, the Botswana study was a very important study, but if you're in a situation where you're able to access partners, and Helen said it's very difficult to be able to do that, but in a situation where you are, I mean, it's almost common sense. Why would you not want to treat the infected person and get a twofer? You get the infected person treated, and you don't transmit it to the uninfected person. If that's possible to be implemented in the situation your country is, I think we've got to be fair, because the people will go to WHO and say, you know, guidelines for what? Guidelines for the situation in which you're in. So hopefully the science can even help to be able to answer the questions of, under certain circumstances, what is even effective or implementable. And that gets to implementation science.